Chetan holds a position as a professor of surgery at University College of London. He's the director of surgery and cancer at Whittington Hospital, London. And he will talk about one of his babies, OAGP, weight regain after OAGP.
Thank you very much. It's a pleasure and honor to be here. Thank you again for the invitation. I know I'm standing between you guys and a long morning and the coffee, so I'll try to stick to my 7 minutes. So I'm here to, and in a way it is good because I think Jessica, Jean-Marc and Kathleen has already covered majority of what I'm going to say. So I'm going to talk of strategies for recurrence weight gain following one anastomosis gastric bypass. These are my disclosures, just to let you know, more than 50% of my work is one anastomosis gastric bypass. So this talk is about this. So we do have patients with obesity, we do this operation, patients lose weight. So what is this talk about? What happens after a long time? And I think that's where this discussion happens. Like Jessica touched on, first we have to be mindful that the definition of weight regain, weight recurrence, inadequate weight loss is quite gray area, and there are multiple definitions here. So when you look at the literature, you really have to be guarded what you make out of it. Okay, so it's not clear cut. So as you can see, different parameters, excess weight loss, TWL, IWL, and so on and so forth. Next, we also discussed that it's not just straightforward, it's multifactorial, the whole weight regain or suboptimal initial weight loss result as well. And all these parameters need to be taken into account before you actually just go and do surgery. So as a surgeon, yes, I want to go ahead and just revise or correct things, but that's not just a straightforward answer when it comes to that. So I went a big step back. Why don't we actually predict the patients who are going to do bad in the first? Bad is a stigmatizing word, so I would say have suboptimal outcome there. This seems like a summary, but this is all the different literatures. There is not a definitive systematic review or meta-analysis looking at that, but when you sum everything up in literature, this is what I found. It looks exhaustive list, but it looks like male gender, older age, IBMI, eating disorders and psychological disorders kind of seem to be the trend everywhere else. So I think before going for even a revision or a strategy for one anastomosis gastric bypass, we should start thinking of this before. Coming now then to one anastomosis gastric bypass. Like I mentioned, the definition is quite vague. This is when we first reported around 13,000 patients of global mini gastric or one anastomosis bypass. What we found was only 6 articles actually reported or even touched on inadequate weight loss or weight regain in it. So you can imagine either it is underreported or it is not clearly defined. So going on to diagnostic modality, once the patient come back, again I think Jean-Marc Chevalier already touched on those. It should be a multidisciplinary team approach with dietetics, psychologists, nurse, physiotherapists, and all eating disorder and psychological things should be looked into. And I think we all would agree that the anatomy of or the surgical problem should be looked into. So obviously the gastrogastric fistulas, endoscopies, barium, CT with 3D reconstruction if possible. We are a poor country, so we can't afford 3D reconstructions in all hospitals, but I have seen beautiful images out everywhere. Gastric pouch dilatations in length are something to look for. Also, I think we have to be honest and also look or talk in the MDT. Should we offer the wrong operation to the patient to begin with? Once you then have a diagnosis or you know that, okay, we have weight regain or suboptimal weight loss as the issue, how do we proceed further? I think we already made a consensus here in the morning, or the discussion is already there, that it has to be a multimodal approach. It's not just about going with one. And I always like to give this analogy forward. I think what we all need to realize is, Thanos, who are the Marvel fans, sorry if not, you won't get much out of this. This is chronic obesity is the problem. With that comes all your obesity related issues. Now it's not, we know from the movie series that it's not just easy a one-man show to go and defeat Thanos. So then comes the multimodal therapy, right? I like Iron Man, so obviously I am the OAGB Iron Man there, but it's not in his hands hand to just defeat Thanos single-handed. You can see we needed a long team there to conquer that critical. And the same thing is with obesity and weight loss and weight recurrence and on and on and on. So I think that probably is the message there. So let's see what is the role of pharmacotherapy out there in this. So there is no paper related to pharmacotherapy and one anastomosis, so anyone in research, that's something to look for. So we can kind of compare it to what happens with Roux-en-Y and take it from there. Weight regain with that semaglutide, 50 patients, we found that yes, you lost weight, but going one step further, they compared liraglutide and semaglutide. Semaglutide did better than liraglutide when it comes to results. So that's one. There's another paper looking, I think somebody touched on it, weight regain and insufficient weight loss, 44 patients. Majority of the patient lost only 5% weight loss, some lost 10% weight loss at 6 months. So that is role of semaglutide. These are the only kind of limited evidence related to bypass, but like I said, in there are comparisons with sleep, so I couldn't include them for my one anastomosis gastric bypass. Jean-Marc touched on endoscopy, weight regain after that. Again, there are only papers in Roux-en-Y, not in one anastomosis separately, but this is probably the largest series, 331 patients, total weight loss is 1, 3 and 5 year, 8% weight loss, so not very dramatic after that. Also they added pharmacotherapy in it to help as well. So again, it was not just one thing, it was a combination of two to do that. I won't go in detail about suturing, argon and TOR. Then it brings us to surgery. You can either correct it or you can either convert it. Surgical management for this correction is, I would say, you can either recalibrate the tube or resize. If you look at evidence out there, there's very limited. There are a couple of patients for Jean-Marc series of 1,000 plus patients, where again, if you look, there are only 14 patients and small numbers. So nothing which I can say that this is what you should be doing, guys. Okay. Similarly, when it comes to conversion as well, there is no evidence that if you convert an OAGB to Roux-en-Y, you get more weight loss. As that as well. So no evidence there. Like we touched, we should be correcting any pathologies like gastrogastric fistulas or bend the tube. Again, not many evidence out there for weight regain. There is evidence in primary. Then comes obviously BP limb lengthening, because that's what people tend to say is the bad. Having said that, there is no evidence out there what happens with that as well. When there is no evidence out there, the best way then is to do an expert consensus Delphi. And this is one, and I'm actually impressed that I was just thinking about. There are a few authors of this, including Gerard in the panel, and a few here who are in the co-authors here. So any difficult questions, please ask them after the talk during the coffee. So this is what was conversion surgeries after one anastomosis gastric bypass. And I'll sum it up in 2 slides for you. Bottom line, they were asked recurrent weight gain after OAGB. These were the questions asked. Majority, they disagree. Where did they only agree on? Yes, elongation of BP limb, consensus. But when you do that, you have to measure your total small bowel length, consensus. So those were the 2 consensus they got. Along with that, they all agreed that you should at least have 3 to 4 meters of common limb distal to avoid malnutrition and other issues. Rest all, stapling, resizing and all was not really what the experts thought would give you the best result out there. So yes, we can keep discussing, but that's not what is the experience. Then the next set was suboptimal weight loss. In that as well, the pouch stapling was probably the only where there was consensus. Everywhere else there was consensus, but consensus in disagreement, not in agreement. And then the same 2 questions, total bowel length and at least having 4 meters of that. That's the summary of that paper. Bottom line was these 3 points. Interestingly, like I said, Roux-en-Y was not good for weight loss, but only for reflux or those related issues. I think Prof. Sivalia just mentioned there is another IFSO statement. We have just published this, but again it talks more of a conversion from different procedures rather than one anastomosis gastric bypass. So I can't, it's probably not in this talk. So bottom line, this is the algorithm we have published before. Assess the patient, dietary, psychology, and then have this. But now I think you cannot escape adding either endoscopy or pharmacotherapy to it before proceeding to a surgical intervention here. And last option, convert to Roux-en-Y, but not necessary for weight loss. So to conclude, guys, obviously there are risk and benefit for any revisional surgery, so that need to be discussed in detail. Just to highlight, IFSO has published new terminologies for weight regain and poor weight loss, suboptimal initial clinical response and recurrent weight gain are the term, and the advantage will be in future then we will be able to have some consistency in reporting, and when I look back then I will be able to have some proper data of that. Now there is not much evidence out there. Do we think because either it is underreported or you don't have issues of weight regain with the operation? We don't know. Time will tell, probably in another decade. Predict preoperatively, MDT, multimodal, and future is probably where the most exciting thing lies. Hormones, ghrelin response, metabolomes, genetic, and that's a different kettle of fish. But I think this is where it will be more exciting in the future. So thank you all, and I would like to invite one to the BOMS conference which we'll be having, and then for the IFSO and also as far as Chile. Thank you guys. So say
Thank you very much, Chetan. We stole already 13 minutes from the coffee break, and Sanjay asked me to make the questions in the coffee break. I think it's an excellent idea. So please be back sharp.